side. But we're proud that this year we get to have a debate. We were really excited about having this debate until about 5:15 yesterday morning when one of the debaters, Dr. He, called me from South Korea and said that his flight had been canceled. And he said, I don't think I'm going to make it. And he said, very frazzled and frustrated. But he did say, since he was going to be spending the next 36 hours in the South Korean airport, that he would still make the slides, record the talk, and that is what he's been able to do. I'm particularly honored because Dr. He was my co-fellow. This is a picture of him and his family, the bald guy, and two of the girls are his. But I'm also honored that the other gentleman in the picture was also my senior fellow when I was in fellowship, and he's the guy with the hat who's up here in the front, and he was able to make it, Dr. Sachs, who Dr. He and Dr. Sachs have unexpectedly become very good friends of mine and colleagues, and have kept me on track many, many times. The cute little girl who's showing some sass in the front is not mine nor Dr. He's, it's Dr. Sachs's. And that attitude will probably pervade into his talk as well. So Dr. He's talk, he's not here. He's with us in spirit. It's going to work. But here we go.
I want to thank Andrew Page for inviting me to join this debate regarding oligometastases for pancreatic cancer. Unfortunately, due to my flight cancellation, I could not be there on time to join the debate.
It's maxed 100.
I want to thank Andrew Page for inviting me to join this debate regarding oligometastases for pancreatic cancer. Unfortunately, due to my flight cancellation, I could not be there on time to join the debate. I have to record my debate, and hopefully you can all hear me okay. And hopefully I can convince you for selected patients with pancreatic cancer, liver metastases, surgery can be indicated. Here's my disclosure. I received some research grant from AbbVie. As we all know, pancreatic cancer is a highly lethal disease. The overall survival for patients with pancreatic cancer has improved in recent years. It remains poor. At 5 years, about 12% patients will remain alive. The improvement of overall survival is mainly due to a combination of better chemotherapy, better understanding of the cancer biology, and a safer surgery. So is pancreatic cancer really a systemic disease? To argue this dogmatic statement, we have to look at what we have learned from the rapid autopsy program in 2009 to study the cause of death with patients of pancreatic cancer. Johns Hopkins has established a rapid autopsy program more than 15 years ago. So this seminal paper in 2009 showed not all patients with pancreatic cancer died of widespread metastatic disease. So the picture A here is showing a patient died of locally advanced pancreatic cancer with celiac artery occlusion. Patient died from bowel ischemia and peritonitis. The part B here is showing a patient died of locally advanced pancreatic cancer with very limited liver metastases. So the cause of death was ascending cholangitis. And obviously, most patients would die of extensive liver metastases. The cause of death was liver failure secondary to massive tumor burden in the liver. So consistent with many other publications, this autopsy study showed uh, about 8 to 15% patients only died with locally advanced cancer without distant metastases, even without chemotherapy. We also look at the disease recurrence pattern for patients with pancreatic cancer very, very recently. So clearly, you can appreciate pancreatic cancer is not one disease, but composed of many different subtypes with very different patterns of metastases. So the part A is showing the recurrence pattern. So you can see up to 24% patients, they only recur locally after R0 pancreatectomy. Local recurrence tend to happen earlier. The median time from surgery to recurrence is 6.9 months. Sorry, that was a liver recurrence. Local recurrence tend to occur late. Liver recurrence tend to occur earlier. While the prevalence of liver recurrence diminish over time, both local and long-only recurrence uh, occur late, typically occur 2 years after surgery. So for those patients with local-only recurrence, there are opportunities to involve a neoadjuvant treatment strategy to improve R0 resection rate. There's obviously also room to improve surgical quality, reduce post-op complication, and start chemotherapy on time after surgery. So what has changed since 2009? In 2009, we lack sensitive tumor markers. We don't have effective chemotherapy. We do most pancreatectomy open approach. With many patients, 20% chance had major wound complication. Now in 2023, other than CA19-9, we're characterize pancreatic cancer into different subtypes. For example, basal with classic. We have better chemotherapy modified for FOLFIRINOX versus gemcitabine and nab-paclitaxel. We also do way more minimally invasive pancreatectomy with almost no wound complications. Again, as I said in the beginning, most patients with pancreatic cancer presented with metastases. So for those patients with metastatic pancreatic cancer, the current guideline is recommending multi-agent chemotherapy with a palliative content. Most patients have median survival at 1 year. But pancreatic cancer metastasis, as I showed you earlier, truly represents a spectrum of disease rather than a binary state. So oligometastases may be more sensitive to local regional treatment rather than extensive systemic disease. So here's a summary slide reflecting our better understanding of pancreatic cancer biology. Now, checking germline mutation for every patient with pancreatic cancer is the standard based on NCCN guideline. Although the majority of patients still presented with no family history, no detectable germline mutation, if you do a different test, such as HARD detect, you may identify another 10% patients who may benefit from platinum-based chemotherapy, such as FOLFIRINOX. More institutions are adopting RNA sequencing study to classify pancreatic cancer into basal versus classical category, which may help the chemotherapy recommendation. For example, even without RNA sequencing, you can use IHC to detect the GATA6 expression as a surrogate to distinguish basal and classic. All those extra biological knowledge will help us to define pancreatic cancer or even metastatic pancreatic cancer better, to identify those patients who may benefit from a combination of chemotherapy and surgical resection. So is pancreatic cancer a truly localized disease, a systemic disease, a spectrum of different situations? I think the key question here is, can we select truly localized disease for aggressive surgery with high quality? Can we use effective chemotherapy to convert some systemic disease to localized oligometastases, and then select those patients for surgical resection? This is very similar to the Asian yin and yang theory, that patient with truly localized disease will benefit from surgery and chemotherapy combination. So at Johns Hopkins, we typically select those patients after chemotherapy for a combination of surgery, resection of pancreas primary tumor and liver metastases. There are many different scenarios. The three common scenarios are listed here. The first scenario here is recurrence in the liver after a R0 pancreatectomy. If the recurrence is less than 3 and resectable, we define this as oligorecurrence, and after chemotherapy, we'll resect the liver metastases. The second scenario is we remove the liver metastases first, and with more chemotherapy, if we can confirm no other detectable liver disease, then we remove the primary tumor. This is an uncommon scenario. The most common scenario, which we should really study with a randomized clinical trial in a prospective setting, is the so-called synchronous liver metastases. For those patients presenting with less than 3 or 5 resectable liver lesions, if they are responding to the chemotherapy, we should consider resect both liver and pancreas lesions. Without effective chemotherapy, surgery alone for pancreas and liver disease will be futile. This has been confirmed by numerous retrospective studies across the whole world. This is one of our recent publications from Johns Hopkins is showing if patient responding to chemotherapy with liver-only resectable metastases, if they underwent surgery to remove the primary pancreas disease and and metastatic liver disease, their survival was better than those patients who had no surgery resection. Again, even for those patients who had both primary and liver metastases resected, you can see here their recurrence pattern is also very similar to those patients with pancreas-only disease. This is one of the representative study from Germany, from Heidelberg, again showing after chemotherapy, if patient the final pathology showed complete pathological response in the liver metastases, their survival is way better than those patients who still had residual disease in the liver lesions, reflecting the importance of the effective chemotherapy. For any clinical trials, we have to understand the importance of the definition. This is a very good recent review paper talking about how the European colleagues are defining oligometastases. And this can also be applied to pancreatic cancer with oligoliver metastases. This is a very complex algorithm, but I want to use this photo to show some key messages here. Again, they define oligometastasis into a different setting. Uh, Looking at the lung here and thinking about this is the liver. So if you have synchronous oligometastasis and responding to the chemotherapy, so on the left side, you can see you have to define what is synchronous, what is metachronous. And if the primary tumor can be removed and then recur later, this is defined as metachronous oligo recurrence. If primary tumor was removed and after chemotherapy, then the patient developed oligometastases. This is defined as metachronous oligoprogression. Then on the right side, if you look at the column C, again, this is a very complex description of oligometastases. In the column C, you can see here in the beginning, patient presented with multiple metastases. And after chemotherapy, if those lesions become less than 3 and resectable, this is defined as induced oligorecurrence. And then the second part of the part C, you can see here, is so-called induced oligoprogression. Again, induced oligoprogression, those patients typically they don't do well after surgery. So I think we truly need to focus on the part A, the top scenario, which is again called synchronous oligometastasis. Slide here. This is what I think we should do in high volume centers in 2023. Patient with confirmed diagnosis of pancreatic cancer and synchronous liver oligometastasis, they should all receive induction of effective chemotherapy. And then those patients can be randomized based on the response to the chemotherapy to either surgery to remove both primary and liver metastases versus the best medical therapy. This is the only way to address this debated issue. I believe with effective chemotherapy, if we select a patient well, patient will benefit from the resection of the pancreas cancer and liver metastases. And future progressing surgery is dependent on biomarker-driven RCT. I'll stop here and I also prepared a couple of cases for Andrew to show to get people's opinion. Thank you for your attention. I apologize for not being there in person to join the debate.
So for those of you who weren't here at the start, Dr. He got stuck in Korea. His flight wasn't able to make it, so that was recorded for the conference from the airport in Korea. So we thank Dr. He for doing that. I'm not going to go through his cases for the sake of time, but I do want to turn it over to Dr. Sachs and then Dr. Reef. We're happy that he and I are, all the three of us are going to figure out how to moderate this without Dr. He, but it'll be fine.
All right. I'm not as tall as Andrew. Very few people are. Thanks for having me. Dr. He is, of course, one of the premier surgeons that I know and one of the most intelligent. And so I was actually a little nervous debating him, despite the fact that I've known him for almost 10 years, about the same amount of time as I've known Dr. Page. But I don't know if it's better or worse that he's not here for my debate purposes. But I'm going to take the con approach. I'm going to say that for oligometastasectomy for pancreatic adenocarcinoma, you should not do it. Don't do it. The antithesis of the Nike slogan.
Dr. Sachs, just a second.
Yes.
Since before we started, so oligometastasectomy, long word, hard to say. What it means is that you have a cancer that has spread outside of its normal place. So in pancreas, it means you're taking out part of the lung or part of the liver or another spot that's not the pancreas. Oligo just means a few. And the reason why this is an important debate is it's a developing science. So when Dr. Sachs and I were in training, when you said oligometastasectomy and pancreas cancer, most people would say they should not even be in the same sentence. But the science and the technology and the surgery is getting better, and that's why this is a really important discussion.
Thank you. I have no disclosures. Someday I may have disclosures. I look forward to that day, but I have none yet. So I wanted to start this more about, well, why would we remove a metastasis? Why would we even think of removing, as Dr. Page mentioned, we never have before, why would we even think of removing metastatic pancreatic cancer from someone where they have a metastatic focus in their liver? Well, it works in other cancers. That's one reason. Up until about 20 or 25 years ago, patients who had colon cancer that had spread to the liver, we didn't operate on them. And now we do. Now, not only do we operate on them, we operate on them multiple times. If they recur again and again, we'll operate on them. And they have survival rates in upwards of 40%, maybe even 50% in select cases. We'll even do it for other metastatic diseases, breast cancer, kidney cancers, and ovarian cancer. That's the hallmark of ovarian cancer treatment, is to go back again and again and debulk and remove as much of the metastatic disease as you can to prolong survival. So makes sense. It even works in other pancreatic cancers, right? So neuroendocrine cancer, solid pseudopapillary cancer. We've talked about it today for neuroendocrine cancers, how if you have a neuroendocrine cancer in your pancreas and in your liver, at the same time, you can do that surgery, remove them both, and you have a clear benefit in survival and cure rates. And many of you probably know the picture here of Steve Jobs. Whether or not he chose the right path early on, he eventually did undergo surgery and removal of his metastatic disease for his neuroendocrine tumor, and he survived 7 years. So it works there. But not all cancers are the same. And most of us in this room know that, and some of us all too painfully. So it really doesn't work in a lot of other cancers. There are some that it does, but not all. Esophageal cancer, terrible cancer. When it's out, one of those expressions, when the cat is out of the bag, which is what we often say in surgery when a tumor has escaped the primary organ and spread to others, the operative options don't yield great cure rates. There's Jimmy Carter. He's one of the few that did beat the odds. He had a melanoma that spread, and he was fortunately in a group of patients who had an appropriate mutation. He was treated, and he's lived a long time with his melanoma having been removed from his liver. But in general, it doesn't work in other cancers. And I would say that right now, at least, it doesn't work in pancreatic cancer. So there's lots of studies that prove this, going as far back as, well, further than this even, but one of the first early studies was by Takata, and they had 100% recurrence at 6 months. This was followed by several other studies, and then in 2006, they had a slightly better showing with overall survival at 5 years of 16.7%. Shrikande, a median overall survival of 11.4, 10.4, 7.8. You can see the numbers aren't getting better. So why else would we do a metastasectomy? Why else would we as surgeons decide to remove it? Well, it's resectable. We've seen it. We've seen it in other, we can see where it is, and it's nowhere else, and we've got great imaging. We've got PET scans, we've got CT scans, we've got MRIs. It's just there, it's nowhere else. We can do it. We're surgeons. Some of us are really good surgeons. But I'll take a quote from Jeff Goldblum in Jurassic Park. I'll switch one of these words. You know, sometimes we're so preoccupied with what we can do, we have to focus on whether or not we should do it. Another reason we want to help our patients. All of us want to help our patients. That's why we're in cancer care. But emotions can sometimes get the better of us. And sometimes we have to remember that the emotional side of things isn't always the answer to what we want to do. So I have a few patient examples, and I hope that in presenting them, I don't open up any wounds for anyone, but I just wanted to present them because these are personal patients of mine that I've dealt with. So this was my first patient who I did an operation to remove a metastatic focus in their liver. He was 46 years old. He presented with painless jaundice. We had a plan for neoadjuvant therapy, and I took him to the operating room first to do a diagnostic laparoscopy, where we go in with a camera and we look around to make sure there's nothing that any of the imaging is missing. And sure enough, he had one little dot, tiny little dot on top of his liver that I could see. And we biopsied, we took it out, and we sent it to the pathologist, and sure enough, it was his cancer. So we stopped the surgery at that point, of course, and he got his this is his original scan. You can see the tumor there in the front. He had a stent already in place for his jaundice, and his operative post-laparoscopy PET scan, that area that you can see lighting up in the liver, that's the area that I removed his metastasis. It was still lighting up a bit from the probably from the inflammation of the surgery, but he had no other disease anywhere else. So we discussed him at our tumor board, as we often do, and we gave him, well, neoadjuvant therapy. That's usually of course, for patients who don't have any, who are on the pathway to surgery, as you all know. So I put that in quotes. But we gave him his chemotherapy, and he tolerated it very well. He was young. We discussed him again. We discussed it with he and his family about what we were doing. We gave him some time off of chemotherapy to make sure that we weren't just seeing the durable response while he was on chemotherapy. We repeated all of his imaging. Good response in the primary tumor, no evidence of anything else. And so sure enough, we went back and we did his Whipple operation, and we wedged out that area where his prior tumor scar had been. And he recovered really well, and we were all very, very happy. We gave ourselves some high fives. But about 10 months later, he started having headaches, and he started to walk with an unsteady gait. And sure enough, you can see there's a little bright dot in the back part of his brain there in his cerebellum. And there were new dots in his liver. And so with him, he didn't get to see his kid graduate. And I was left wondering, well, would he have if we had just left him on chemotherapy instead? And I wondered if we had made the right decision. Another patient, one of the other reasons we often talk about in this circle is well, if they've had a really long interval, if they have a really long time between the original surgery and their metastatic focus popping up. So this is a 71-year-old woman, very fit. She had a Whipple in 2017. And about, I say 2018, but it was about 18 months later that we saw her metastasis show up. And then she ended up going on palliative chemotherapy for 16 months. And she just had the one lesion there in her liver. It was rather big, and it was kind of near where her gallbladder had used to be, but she had nothing anywhere else in her body. She was otherwise doing well. Her CA19-9 levels had come down. And so we discussed with her and her family, and we discussed in our tumor board, and we decided to go ahead and take that out. Unfortunately, when we got in there, it was a little bit more stuck to some things than we had expected. So we actually had to remove part of her colon too. But we thought at least we were not going to touch her tumor. We were taking everything out en bloc, and she recovered well as well. And again, more high fives. And about 7 months post-operatively, she came in with symptoms of a small bowel obstruction, and she had disease elsewhere in her belly. And she went back on chemotherapy and lived for a while longer, and she was always very stoic, and she was always very proud of the decision she made with us to go ahead with the surgery that we did. And this one was especially difficult for me. This was a patient from Kenya, and she had presented initially with a gastric outlet obstruction, which means the tumor was pushing up at the edge of her stomach with the inflammation, so that her stomach couldn't empty. And we actually took her for surgery right away. She didn't get neoadjuvant therapy. We took this out because it hadn't shown any evidence of metastatic disease, and she got better, and she did really well. Her operation was in 2015. She had a recurrence in her renal pelvis, so right at the area where her kidney, kind of if the kidney bean, in the concave portion of the kidney bean, where the ureter, where the tube that takes the urine out from the kidney, she had an area there, and we thought about it for a long time. We figured, well, maybe this was like a cell that had fallen off when we did the original surgery, because that's right where we are when we're doing our dissection. And so she had hydronephrosis, which means the kidney can't get the urine out of it, and so it swells up like a big sack of urine. And we discussed her with our colleagues, and we elected to take her to the operating room. We did a nephrectomy, and we took out the ureter, because she had been almost 3.5 years without any disease recurrence, and she recovered very well. And sure enough, there was cancer right at that area that we thought there was. And we were optimistic. But about 11 months later, she came in. She wasn't able to eat. Her belly was very swollen. And sure enough, she had developed these cystic tumors of metastatic pancreatic cancer in her belly. And so, I don't use the word regret, but I did like this quote, because it's true that when we're always looking forward, it's very hard to see what we're going to see when we get there. And sometimes you have to think about, well, what is the best option? Not what we can do, but what we should do. And a lot of that goes back to what's been discussed today. What are the goals of the patient and the team? And what is the quality of that life versus the quantity of that life? And so while Dr. He is right in a lot of what he says, and the best way to go about answering the question that we have before us is certainly with a trial like he suggests, I still say right now that for oligometastasectomy and pancreatic cancer, we shouldn't do it. And that's what I would say in a forum like this. But when faced with a patient in my clinic, I've got to be honest. And there's honest Abe looking me in the eye, and the fact is, I'm probably going to do it again. So if we're going to say don't do it, which is really what we should be saying at this juncture, then if you're going to do it, don't do it just because you can. Don't do it because it's emotional, because all cancer is emotional. It's all very personal for everyone who's affected by it. And you got to be honest with yourself and with your patient about what the goal is and whether or not your goals are aligned with what the surgery is likely to entail. And I'll leave you with this quote, which is, I think, a very good one, because progress, we can't move forward, obviously, if we don't try, but there are always going to be risks involved, and we have to assume those risks if we're going to make any progress. So thank you.
So I'm going to turn it over to Dr. Ree for some comments, and then I'm going to try and act like Dr. He and argue with Dr. Sachs.
Okay, so great presentations. We appreciate the honesty at the end of that last talk about intellectually, maybe we shouldn't do it, but when faced with people sitting across from you, I think that we're still trying to find the best way to help our patients. So I would say in terms of practical aspects, I guess the first one is for patients that you don't feel are ideal surgical candidates. Maybe you should sit on the ground and that would you refer those patients who are unresectable for radiofrequency ablation, Y90, non-invasive methods in terms of disease control?
So I should rephrase. So ECOG 0, unresectable.
Let's just assume all these patients are the same. They've received some course of systemic therapy. They either have some tumor response or stable disease, and their metastatic lesions have not progressed.
Yeah. So tumor markers, we'll just make them all the same.
Yep, all stable.
All stable. Disease for duration of stability, a year?
No, duration of stability. Let's say we've given them 2 to 3 months of systemic chemotherapy.
Yeah, I'm going to speak personally. I'm not going to be Dr. He. That's too hard to do. I would not. I would unstable liver disease, resectable primary. I think I'm going to quote you. I mean, do I really think that patient can get to a cure? I don't think so, but I think I can potentially prolong their survival, and but prolonging it more with systemic therapy over surgical therapy. What do you think?
Yeah, I tend to agree. Although I've rarely seen a downside and to an RFA or a microwave ablation of a single solitary focus of metastatic disease. So if we were trying to get that patient to surgery, that might be an ideal candidate. But I would probably wait a bit longer than 3 months before I would try to pull that trigger. And I think the other option, really, hopefully in the future, as was discussed by our keynote, is the cerumen and the vaccine trial, and now then maybe you have a really good candidate.
And along those same lines, and I think Dr. Szabo and Dr. Fleming mentioned, and this is where I think Jen has some validity, or Dr. He, when he was talking about we really can't lump everybody together. We really can't. I mean, Szabo mentioned this, and he kind of harps on it. I agree 100%. Is that we don't know enough about these tumors. I mean, the classical basaloid. I mean, we're just now starting. I think at least our group is just now starting to appreciate that distinction. But I think that's just the tip of the iceberg, and I think that's where the basic science comes into it. But I think I've seen some issues with RFAs while patients are on systemic therapy and ablations, and they get these nasty abscesses, and they're in the hospital and drains. So I would err on systemic therapy versus trial.
Would you offer metastasectomy to those rare patients who have isolated pulmonary metastases or isolated radiographically apparent peritoneal metastases?
Lung, yes. Peritoneal, no. You agree? Dr. Fleming, what do you think?
The burden is always on durability, and are you seeing everything? And so these are really tough cases. You have to, how much do you patient? This is the toughest discussion with the patients, is the durability discussion, where you're like, well, we want to make sure this doesn't grow, somewhere else before we do surgery to take out the thing that we know about. And they're like, well, why don't you just take it out and then we'll talk about the other, you know? But like we talked about in my talk, there's consequences to any intervention, immune consequences. So you have to be, I mean, the ideal is that the big operation is the last thing that you need, because you can't get, there's no systemic therapy for 8 weeks after a big surgery. So you're in kind of the no man's land there.
About oligometastatic disease. I'm not, I think we all are very mechanical about things. We see a spot there and it's a couple of spots and the patient asks, can we take it out? And I ask, can we take it out? But as you alluded to, is that really the only disease? Because we all know that our PET scanning, our MRI, CT scanning are just indirect images using physical characteristics. And so honestly, lately, in the past few years, when I do think about metastatectomy, I'm actually trying to think about how can I initiate an abscopal effect? Really, and for those who don't know what an abscopal effect, you have somebody who has widely metastatic disease or a few metastases, but you locally interact with that tumor and you do something, you perturb the immune system and it eradicates all the other disease. And I'll give you an example of a patient I had 10 years ago. It was a nice gentleman. He had metastatic pancreatic cancer through his entire abdomen. And I just wanted to feel a little better. He was having some pain around the porta hepatis, around the liver. So I asked the radiation oncologist if they could do radiosurgery to a lymph node around the liver because that was bothering him. And it all went away, everything. His entire disease went away. It was all gone. He doesn't even follow up with me because he doesn't even want to go to the clinic anymore. I don't blame him. He's fine. And that made me feel great, although I know I didn't do anything. That wasn't my intent, but it made me learn something that there is such a thing as an abscopal effect. We should think about it more. We, as Dr. Fleming knows, we have checkpoint inhibitors, and we're essentially doing that right now. But when we think about metastatectomies, I would encourage our surgical colleagues when they're developing their trials, maybe they want to think about when they go in, what modality are they using to remove the tumor? Is it with a knife? Are they vaporize, can they produce a lot of antigen without spreading tumor to create an abscopal effect? Or can you prime the patient before surgery? And they are doing studies with checkpoint inhibitors, going to surgery and seeing if they can create that abscopal effect. So I think it's great to think about metastatectomy. I always tell my patients, I think cancer is clumpy. I don't buy I think it's this disease that's spread throughout. I think in some cases it is, but not always. And again, as we alluded to, it's always patient selection, but it's just something to think about.
Jay, do you want to close us out?
No, I think that we're almost at our time. Just the last question is sort of where the rubber meets the road. Once again, I appreciate your honesty. Is between the three of you, if you had a patient who was 50 years old, had 6 months of systemic control, has stable disease, would you offer that patient a metastasectomy?
Lung, yes. Local recurrence, yes. Liver, no. And peritoneum, no. Just completely based on personal practice.
I'm going to take I'm going to say I don't know. I just don't know. And it really is, it's like Blake Cady said, biology is king and then selection is queen, and the technical abilities of the surgeons and their tools and everyone else who works on these patients. Those are the princes and princesses. So we've got to we've got to let the king and queen decide whether or not we're gonna operate.
So I'm kind of with Andrew on that answer. I think I think obviously he wouldn't or I wouldn't talk to an individual patient that way, right? I mean, because you wanna offer every opportunity. I have a case. Debbie and I were just talking yesterday. He told me about his case, and I have a case just like that. Same sequence. Liver met, removed, went back, did Whipple, cerebellar recurrence in the brain. So we're all just trying. People need to know that you as your team are advocating for every possibility for success. We're kicking over every rock, but you don't want to replace that. You don't want to replace safety with that urgency. You can't. So I tell patients there's 4 things in a row that never change, at least in hopefully in my sphere. Safety is number 1. 2 is oncologic efficacy. 3 is functional and cosmetic outcome. And you could say those are together maybe, right? Because we learned 4 is fiscal toxicity, right? I mean, we have to be stewards. We can't, and so we have to stay in. That's our lane. We have to stay in, I think.
Stay in our lane. Thanks, Dr. Fleming. Dr. Ree, appreciate it. Dr. Sachs.